us and your first symposium of chronic disease. And this is from Zagreb in Croatia. Why we love our interest why our interest is chronic disease? Because increased prevalence of chronic disease. Why increased prevalence of chronic disease? Because of eradication of infectious disease, across antibiotics and vaccines, and decrease of violent deaths in global, positive social political change, improved social conditioning, and also increased health literacy and health behavior. And third, progress in medical intervention which change courses on an outcome of disease. Because of mentioned, today we have paradoxal situation, benefit of synergistic effects of civilization development, leading causes of death invest a chronic disease today. 73% population today dies of chronic disease. In past presentation, we in Finland is 82%. By prolongation of lifetime, about past decade, lifetime is added in age over 70, not in age 40 to 80, over 70. Chronic disease is cause of death globally today, known today before COVID-19. In North America, Europe, and Australia, and Japanese, 73% people die of chronic disease. In the future, we expected this percent in in a country with large population like Russia and India and Turkey. When chronic disease will increase in South America, China, and India, proportion of chronic deaths, diets of chronic disease increased for 32%. It is global problem. World Trade Organization, according to that, give necessary structural components in chronic disease, special care in family physician. These structural components is first, secondary prevention or early detection, but not universally structural, but not universally secondary prevention, but based on risk, likelihood that the disease might risk is component from what chronic disease may develop. Patients cannot symptoms. Other is treatment for tertiary prevention. Symptom is present, clinical picture is presented. Our duty is treating chronic disease according evidence-based, recommended and guidelines for treating different chronic disease. Because additional 10 years in age over 70, we have one other problem. It is multimorbidity. Multimorbidity appears mostly over 40. Definition of multimorbidity is presented 2 or 3 and more chronic disease. Multimorbidity is new diagnosis, is new burden of family physician and all health national countries. How we discover or how we discover disease in asymptomatic parts? In family physician with opportunistic screening. Opportunistic screening is a natural base for early detection of chronic disease. What opportunistic screening is stratification, patient, division of patients in groups with or without risk for asymptomatic disease. And we must answer why family physician. Family physician is only part of healthcare which are familiarity in all specialists up to a certain level. With disease in patients and his care familiar, continuity of care, and all report, all data is recorded in evidence medicine data. Family physician meets 80% patient annually. Family physician is a professional is professional qualified for screening. Family physician is familiar with communication and cooperation with patients and with all secondary and tertiary care. Behind opportunistic screening, we have a national program for national secondary prevention in Croatia. It is universal screening with only 2 risks, non-variable risks, age and gender. Universal screening, national universal screening, is for disease which affects specific age group, which disease symptoms occur in late phase and disease with high mortality. Early detection of the disease involves specific examination, sophisticated equipment, and education professionals. Today, Croatia has 4 universal national screening for breast carcinoma, for cervical carcinoma, for colon carcinoma, and lung carcinoma. in screening or early detection disease, what went wrong in secondary prevention. Unrealistic goals is eradication of risks, lowering limits for demarcation health disease. This is becoming to third entity, mind disease, or health risk incorporated in pre-disease and disease. According what happened? Why? According to diagnostic technology, biomarkers, and widely available tests, increased medical superfluent information, unclear delineation values for health and disease. Metric and biometric commercialization is dropping. Pre-disease as risk one or most risk is slowly becoming surplus diagnosis. Escalation of surplus diagnosis is in this entity, thyroid, prostata, etc. Surplus diagnosis in the system gets slowly characteristics of disease. And other problem is, according to our classification, possibility of classification, most risks are recorded as diagnosis. Diagnosis as according to ICD-10 and ICD-11. We not have code for risks mostly, but we must record risk as disease. My great pleasure is that we perform investigate in Croatia, North Macedonia, and Kosovo. Opportunistic screening for diabetes mellitus. We have short time and I cannot explore all investigate. You can see you in a health public journal, recent journal, and our investigation, which conduct Professor Linda Karkashiu in Kosovo. Food needs, our association have a goal to investigate food needs for screening in primary care. Generally, screening is not yet incorporated in routine practice in family medicine. Why? It is not now, it is not clear. We have no adequate IT support for easy broaching data on risks, outcomes in medical records and continuity of care. And also is very important, intervention after screening, detected asymptomatic disease, and results intervention in routine practice are not significantly different of disease which conduct in routine practice in family physician. This is unclear. This needs investigation in the future. Third entity is multimorbidity. Today, we not know epidemiologic estimate multimorbidity. Why is not possible? Because ICD 10 and 11 records only single disease with additional 3 digits for complication of the disease. ICD 10 and 11 cannot record multimorbidity disease. And also, it cannot record index disease severity, which is more important in treating multimorbidity. This is a map of today presented disease map. Today, most important is SNOMED in America. In family practice, we today's ICPC 2 and 3. International classification disease 9 is Portugal, Spain, 10 and 11. Where is person in this classification? This is individual classification for psychologistic or dermatologistic, gynecologistic, neurologistic. None is synthetic approach multimorbidity to person. Multimorbidity to person. In Croatia, multimorbidity, this is information of multimorbidity, it is similar in other countries. Appearance of multimorbidity from 40 age to 64, one and more disease have about 30% of population. It is a great burden for family physician and health national. Multimorbidity problem today is no pure professional within health system for a synthetic approach to person with multimorbidity. Multimorbidity big deal is also in family physician. But there is a need for a new profile of an additional role of education, family physician for the resolved multimorbidity. Our association is integrative, is international and multidisciplinary, and I invite my colleague, Professor Ivana Renar, which in 2-3 slides explain why we are multidisciplinary. It's a core of our success.
I'm sorry you passed the time, and I tried to be very quick. So we started the program. I am a diabetologist and endocrinologist. So years ago, we started the program of courses for general practitioners regarding diabetes care. Before, it was usually taught by diabetologists to the general, in that time we said general practitioners. Anyway, then we decided it's better to do jointly. So the teachers would be experienced general practitioners and diabetologists. So that's Maria and me and some of our other colleagues. It lasted more than 10 years. We involved almost all the family physicians in Croatia. On the end, we published a book, which is, although now it's a little outdated, but it's still well of use as a textbook, like diabetes for non-diabetologists. Based on this experience, Maria and her colleagues established this Association for Chronic Diseases, and we started in 2011 congresses about how to make prevention and how to do well care of chronic diseases in primary care, involving people from clinics and polyclinics of various specialties to jointly make some decisions. Most of these courses are discussions, not really courses. So far, as you see, we had 6 of them. The 7th will be by the end of this year. Lecturers are family physicians and other not only from the medical society. We had some other professions, including writers. I mean literary writers, not professional writers, where we discuss various items, mostly about chronic disease. We are open for discussion. Thank you very much.